CLD web email here. You can actually email and ask us questions. So let me go back to, oops. Let me go back to the beginning. All right, so today, Julie asked me to talk about our national referral service for the BPD. And it's mainly for severe BPD. We have a lot more patients in our unit with BPD, but we only take care of the most severe ones. On the screen, you can see two lovely kids. These are graduates from our program. This little boy on the left actually just got decannulated last week, and both of them are doing very well. So what I want to do today is through these kind of 40 minutes-ish talk to share with you the experience of our program. We call it NEO-CLD program at the Children's Hospital Philadelphia, and talk about how we started and what is our current infrastructure of the program, how we're doing, and also some of the things we have learned. Okay, so this program we started actually in the fall of 2010, and till this time we have followed over 500 of infants with the most severe kind of BPD, and we grown a lot. We started off with a small consultation service within the NICU, so we couldn't bill because we're consulting ourselves. And at that time, we started off with about 4 attendings. I remember the days that Harish and I think a lot of the audience in this group probably know Harish Kapralani really well. So we started the program together, and at that time, the two of us, along with 2 other attendings, were walking around the unit and do consultations for our severe BPD kids. And 10 years later, we become one of the largest severe BPD program in the world. And it's really a great service right now and very, very active. So why did we develop that program? It's mainly because I listed some of the reasons here. Mainly because, like it or not, we have these babies with severe BPD being referred to CHOP. Being a level 4 referral center, we get these kids whether we want them or not. But then once we got them, what we find is that there's really inconsistent care approach for these kids. In our care service, we have a model of attending rotating every 2 weeks. And at that time, there's not really team designation. So there are about 5 medical teams and 1 surgical team in the unit. And as attendings, we may rotate in any of these teams. And then every 2 weeks, you get a different attending. And all these different attending have different approaches to how they treat the severe BPD. But these kids don't change. Once they come, they stay for a long time. So for the 2 weeks of service, some of the attendings, they have their own agenda. Sometimes they have a grand deal, and they just want to go through these 2 weeks without much to do. So they make no changes. And then there's some other attendings come along very excited, and they do radical changes for these kids. And you can imagine these kids with chronic disease, they don't like it. And these changes make the parents and the nurses and frontline clinicians very unhappy because there are too much changes, and the message to the parents and to the nurses are very different from different attendings. So it is very challenging to manage these kids. Simply, I think the audience in this group probably know really well already. This is a multifactorial disease that with complex pathophysiology. And we really don't have a whole lot of data to know what is the best treatment for these kids, how we best prevent or treat this disease. And the treatment we are using now, a lot of them are unproven that it's safe or efficacious. So therefore the practices varies a lot. I just talked about the variation in our one unit, but nationally there's a lot of variations in the practice. This is a paper published by the Severe BPD Collaborate group, looking at 8 centers with over 350 babies with BPD, and you can see the treatment, the medication use varies really dramatically. For example, the inhaled beta agonist, some units does not use at all. In some units, 2/3 of the babies are on them. We simply looked at one day in December, I think 2014, and how we're treating these babies. And you can see inhaled steroid, it's the same. Some units don't use it at all, and some units, almost 90% of the kids are on some kind of inhaled steroids. So when we look at the population we deal with, this is the patient demographics that we summarized over this 10 years who we take care in the severe chronic lung disease program. And these are pretty premature infants with the mean gestational age of 25 weeks and birth weight of 690 grams. They come to us usually at a postmenstrual age of 38 weeks. So they come close to term. And some of them come early, that you can see the range are from 23 weeks. So they were born in our unit, usually in a special delivery unit with some kind of other congenital anomalies or problems, and then they stay in our unit. But there are kids also come very late. You can see here the upper limit of the range is 68 weeks. So they come really late. And when we looked at how many of them came after 36 weeks, it's over half, it's 65%. And then about 66% come with mechanical ventilation. But on the other hand, although they are all severe BPD kids, 34% of them come not on the ventilator. And so how did we do for the first 2 weeks, 2 years of the program? When we first started, like I said, Harash and I and 2 other attendings, we were a small consultation service. And honestly, people don't listen to us. So the first year, our goal was actually to establish the clinical program, really encourage the multidisciplinary involvement of the program, and increase the awareness of our program within our top unit. After a year, we actually did pretty well. And then from the second year, we started to kind of focus on improving the clinical care of these patients and increase the program awareness in the region or country and within the United States, and also start the some of the research programs within the CLD team. So when we think back how we got started and what make us actually able to sustain, the first step is to establish a core CLD attending group. And thinking back, I think we chose the right person. When Harash and I started the program, we recruited 2 very senior and experienced attending, and then soon after that recruited another attending. So 5 of us were in the program, and we did weekly attending walkarounds. And these are very experienced attendings, and we kind of gave very useful patient care suggestions. And we are very consistent within our group because we discuss a lot. We do argue among ourselves, but then we come out with a very consistent message to the service team. And we're very open-minded and willing to learn. Honestly, after a year we started, we looked at each other and realized how much we have changed ourselves in terms of how we think about these kids and how we approach. So we do believe you really need to stay very open-minded and really want to learn. And then at the same time, we try to get the multidisciplinary team involved, and that including nursing, respiratory therapists, frontline clinicians, the consulting service, including the pulmonary team and pulmonary hypertension team, and our psychosocial team. And we did like monthly meetings and different sessions to stimulate interest and to hear their concerns and suggestions, and very importantly, to involve the team leaders of each individual team and get the buy-in from the nurses and the parents. So with that, we actually made some pretty significant changes in the unit, especially with people's beliefs. There was one attending initially told me, I have been practicing unitology for almost 30 years. I think I know how to take care of these patients. So she was actually my clinical mentor during my fellowship. So you can see how experienced and have to sustain our program and also further develop our program. And I want to talk about how we further develop the program, sustain the program from these 4 different areas.
Oh, Zhang, we can't hear. Sorry.
HUAYAN, you might have to log in and out again. She's frozen. Sorry, everyone. HUAYAN, could you check your internet connection?
Sure.
There you go. You're back again.
I'm back again? Okay.
Yeah, sounds good. Thanks. Thank you.
Okay, let me find my, yeah.
Hi, sorry, I'm on a Zoom call. Okay. Meredith, yeah. Okay, no worries. Bye. Hello, HUAYAN. Maybe you might have to log in and out again. Sorry, everyone.
Julie, can you hear me?
We're just letting HUAYAN back in again. Just bear with us for a moment, guys. Okay, HUAYAN, you're back as co-host again.
Okay, can you hear me okay?
Yes, looks good now. Thank you.
This is so frustrating, huh?
Oh, never mind. It happens. Yeah. Okay, there you go. Cool.
You can see my screen?
Yes.
Okay, cool.
Okay, lovely. Go wild.
Okay, so we, like I said before, we want to emphasize on the team approach and consistency, and at the same time, you also want to pay attention to do constant quality improvement for your patients. So our team care model, what we do, very, very much believe in a multidisciplinary comprehensive care model. And also at the same time, even though we talk about comprehensive collaborative care, we also emphasize on individualized care. And we think one of the most important things for these patients is to change the mindset from an acute NICU management mindset to a chronic support mindset. And the focus of our management needs to stay in providing adequate support for lung growth and lung vascular growth and avoid further lung injury, and also improve long-term neurological neurodevelopmental outcomes for these kids. So this is a picture showing our some members of our team, and this CLD team is led by the neonatologist in the NICU, but you can see a lot of people is involved in this program. So the team is really, really huge. Within the NICU, we have the psychosocial team, the developmental team, our frontline clinicians, our respiratory therapists, and importantly with our nurses, they have a nursing CLD committee, and also our pharmacists, dietitians, and our different consultants of the program. And this is different number of people actually within all these disciplines that participate in our program. It's part of our program. And when you look at what is really the source of our patients, they either come from the outside hospital referrals or they come within our units. So when they come from the outside, a lot of them are parental self-referrals. They found us on the web, they found us in their parental web groups, and then they call us up, or they send an email request to our email on the web. And usually Cassie will answer those and come to us and talk about these patients. But we never directly accept patients just because of parental referral. We always request them to go back to their physicians and talk to us so that the physicians can talk to us directly. And then some of the physicians would request for a consult or a transfer. Now, when you look at the geographic location of our patients, they are mainly from our tri-state area, Pennsylvania, New Jersey, or Delaware. But also a lot of people come from New York, Virginia, and Florida. And we even have international patients from UAE. And in terms of consults, it's really all over the place, around the world. Our goal is really, even we have this service, we don't want just to transfer everybody. When we decide whether to transfer a patient, it needs to take into consideration whether this actually would benefit this patient and the family, how difficult it is, the safety of the transfer, what really they can gain from coming to us instead of staying in their home hospital and we just help. So the patients we admit, the volume varies from year to year, but now settles around 50 to 70 a year. And these are the patients that we follow, and only with severe BPD. And for this last 10 years, we have a total of 551 infants with severe BPD that followed by our program. The current clinical care routines includes two phases. One is the NICU phase. We're not a regular NICU, we're a newborn and infant intensive care unit. That's why we call it an NICU. And we currently have a team, a medical team actually dedicated to chronic lung patients. It's our team. So we do daily bedside family-centered runs, and our team usually takes care of about 16 patients on this team. But at the same time, we consult on several patients in our unit. So our daily census for our program is anywhere from 15 to about 20. And then we do weekly multidisciplinary rounds every Tuesday afternoon. Everybody knows, even the parents knows, that we sit down and talk about our patients the whole afternoon. And for this rounds, all the team members from different disciplines will come. In our daily morning rounds, usually is our CLD attending with the frontline clinicians and nurses and social worker, and sometimes the PT will join us. But most of the time, it's the small group. But at the Tuesday rounds, a lot of people, each discipline will send representatives to join the meeting, and we discuss. And then when family comes, initially we would do an initial family meeting within 2 weeks of admission to talk about our goals and expectations, and also hear the parents' goals and expectations, and also tell them how we work and our initial assessment of the patients. And then after that, every 2 to 3 weeks or whenever we feel needed, we will sit down with the parents again and do a formal family meeting. And then for individual very complex cases, we would have about a monthly single patient discussion meetings with our consultants and talk about those difficult cases. So after we think they can actually graduate from our NICU, there's 3 ways of three directions for them to go. One is for some of the patients are still very sick on the bench and still in sort of an active phase, but they're kind of really outgrown our NICU. We usually admit them till about a year of age, and then they transfer to the PICU. And then in the top main site, we have a unit called PCU, Progressive Care Unit, and it's a vent unit. It's a step-down PICU that's taken care of by the PICU attendings, and then they mainly focused on the trach and vented kids, and very good with parental training. So when our kids are trached and in a stable phase with parental training, we usually transfer them to PCU. For the kids are not trached but not totally ready to go home, there is a complex care floor at CHOP run by pediatricians that are dedicated for complex care patients. We would transfer those kids to that unit. And then for some patients that come from far, we try to send them back to their home institutions or chronic care facilities near home. And then some of the kids are really ready to go home, so that we send them home. For the first 2 types of patients, we're very careful. We do a lot of pre-transfer communications and then do a structured pre-transfer meeting and arrange and do kind of complex transport requests, arrangements for these patients. And for the patients that are going home, we do very good discharge sign out to their pediatricians. They all need to have their own pediatricians. And then all these patients are followed up by the BPD follow-up clinic. And this is, I forgot to change it, this is bi-weekly clinic in the CHOP main site. And it combines the developmental pulmonary follow-up in this clinic. So this is the data that we collected at when we did a 10-year review. The average length of stay once they come to us, remember they come to us around 38 weeks post-menstrual age. They need to stay in our NICU on an average time of 15 weeks, sometimes shorter, sometimes much longer. And then the survival rate is about 88%. The 60% of them eventually directly discharged to home from CHOP. This is not directly from an ICU, directly from CHOP to home. And then some of them discharged to the chronic care facility, about 15% of them. 6% goes back to their referral hospitals. About over 1/3, 38% of the patients needs tracheotomy and home ventilation. And for the patients that directly discharge from our NICU, not vented, 66% of them needs home oxygen therapy. And this is in terms of treatment. You can see for pulmonary hypertension treatment, respiratory medications, diuretic therapies, feeding and reflex therapies, different percentage of different therapies. And then we do a lot of bronchoscopy and CT with angiogram or without angiogram, but not everybody would get these diagnostics testings automatically. So what we have learned from these patients, there are a few key concept changes that I think I want to mention. The first one is the old concept of BPD patients are all the same. And a lot of emphasis on the current BPD is the new BPD and only with delayed ovulation. What we see in this severe population, they have different clinical phenotypes and different underlying pathophysiologies. So we think we're seeing a combination of the new and old BPD that we call them extremely severe BPD. They have features of both delayed lung development and also significant lung and airway injuries. And we see different kind of clinical phenotypes of the BPD. Some patients behaves that really presents with very, very severe lung disease. But some patients, lung disease is not that severe, but they have leading clinical features of pulmonary hypertension, or some of them have leading features of airway disease. This is one of the paper, I forgot to change the reference here. We actually published this paper earlier this year. About 1/3 of these patients have all three features, that they have severe lung disease, also severe pulmonary hypertension, and severe airway disease. And that's actually the most common in this group. And then the second concept we want to emphasize is that BPD is really not just a lung disease. It's a multi-system problem. And when you take care of these patients, you cannot just think about the lungs. You need to do a comprehensive evaluation and management of a whole person. And the third concept is that weaning respiratory support as early as possible. And I used to be like that. When I come on to this 2 weeks of service, I want to wean somebody off the vent or wean somebody off the oxygen. And we find out in this severe population, it doesn't really work. And a lot of neonatologists are used to based on their weaning based on blood gas. And we found that not very helpful either. What we think is important is BPD is, you have to keep in mind, it's a chronic disease, and you need to provide comprehensive support to really support the growth and development of these kids. And the respiratory support adjustment should be based on infant's well-being and pulmonary mechanics. So we do a really comprehensive multi-system evaluation when the kids come to us. Remember, they come around term, gestational age, and we look at how severe their lung disease is, but also we look at all the other systems and and especially how their growth and development stages are. And the respiratory support, we emphasize that the respiratory support is a nutrient for these kids. So you really don't want us to wean, but at the same time, they struggle too much and have severe hypoxic events, or they don't grow at all. So we look at we emphasize what the adequate respiratory support means is no or minimum work breathing. And the babies are able to participate in age-appropriate physical activities and also have good growth in weight, length, and head circumference. So in terms of the respiratory support, when they're on the vent, we emphasize on pulmonary mechanic-based respiratory support. So I put in this slide, if we think this kid has homogeneous lung disease, we call it the one compartment model. You may ventilate them similar to an early RDS kids, even though there are still differences in those kids with early RDS cases. But if you have a lung that is really heterogeneous, we call it a two compartment model, then we ventilate them with different philosophy. So these are some of the reviews that we have published in the recent years. Our team members actually participate or mainly drove the manuscripts. So you can, I list the reference here that you can find them and read them if you're interested. And these are the clinical models and our beliefs that how we manage these kids. But at the same time, I think when you manage a whole group of patients, you have to constantly think, what can we improve? So these are some examples of the quality improvement initiatives that we have carried out in the last 5 years. The one example I gave here is the CLD immunization. What we find out is usually when these kids come to us already term, none of them have, some of them have never had any immunizations. So, and in people's mind, these kids are too sick to actually give them vaccines. And we don't believe that's the case. So we did this quality improvement initiative and actually found out we can safely give vaccines to these kids, and we dramatically increase the vaccine rate. The other ones are hearing screening, that we found a lot of kids actually have hearing issues when they have severe chronic lung disease. So when we address their lung disease issue, we also need to address their hearing problems. That smoothly. And in terms of the team education, we have fellows elective.
HUAYAN, I think you are frozen again.
你最好的病理吧是个啥？你长的这地方非常有。
Julie, can you hear me? Julie? Okay. Can you start? Julie, make me
Hi,
co-host
yes.
again.
Can you just keep going, HUAYAN?
Okay. You have to make me co-host again. I can't share my screen.
Okay, hang on. Okay, sorry about that, everyone. Okay. All good?
Okay.
Okay.
Here we go. All right. Sorry about it. So this is the part of the parental information that we gave them. We have them on our webpage, and everybody, when they are admitted, we gave a package to the parents explaining the disease and our team, how our team functions. We do a lot of parental skill teaching, and in addition to the normal baby care, we teach them the feeding skills, medication administration, airway skills, and also emergency response skills. So it depends on what the baby is being discharged with. So if they're being discharged with a trach and home ventilation, the parents would need to go through a very extensive trach care training. This is examples of week 1 to week 8 trach care training. So usually we start them in our NICU and then transfer the kids to either to the PCU or to a chronic care facility for them to finish the training. And the third area is to develop our program is research, of course. And we feel we have the obligation to contribute to research. So we promote multidisciplinary research and also national collaborations. To teach the team research efforts started off with the retrospective case series and then moved into the prospective cohort studies and trials. And we started the research actually a lot to do with Harsh, and he was a very good leader for us. And also Dr. Panich from pulmonary and also PT team have research advisors. And we have several young investigators in our team are dedicated for research. So this is an example of a paper we published. And this is a result of the collaboration with multiple disciplines, including the physical therapists, the nursing team, pharmacists, and attendings, and even international visiting physicians. And these are examples of our research national collaborations and some of the sample research projects we have done, or some of them are actually ongoing. And some of the data, I don't have time to really go through the data in detail, but I want to just show you some of the data we generate from the program. This is a abstract we reported in the PES in 2014, and looking at the feeding difficulties in babies with severe BPD, and found a lot of them are really not safe to orally feed. And this is a paper we published with looking at colonization of the tracheoaspirates before 36 weeks and the correlation of the outcome at discharge. This is a paper looking at reflux and BPD because we do fundoplications, and we looked at before and after fundoplication, what's the difference. And we did see some small signals here. And then about metabolic bone disease in babies with severe BPD, and we found the incidence is really, really high. It's about 90% of them, and some of them have fractures. And this is very directly related to medication use for these patients. And this is a paper published looking at tracheobronchomalacia. And this is a condition that we gradually realized how important it is in the BPD population, because initially we didn't recognize the airway component of the disease. And then again, the hearing loss issue that I talked about, that we did a quality improvement project for it. And this is an abstract looking at the 2-year neurodevelopment outcome of the babies graduated from our program. And the paper we published looking at adequate respiratory support and relationship with the growth and development in these patients. This is data that we reported in PES 2018, looking at our trach kids, and reported the duration of trach and how they do with their respiratory support, so that we can have some ideas when we counsel the parents. When we talk about trach, it's really not a few weeks, we're talking about a few years. And this is a paper we published along with using the data with American NRN, and looking at any respiratory support and outcome. And this is a prospective cohort study looking at the severe BPD kids, and we're trying to identify whether we have a way to identify intrinsic PEEP in these kids. And this is a paper published last year. And Dr. Eric Jensen did this N-of-1 trial comparing the transpyloric fees versus continuous gastric fees, and whether it's true that transpyloric fees is definitely better than the gastric fees, which we found not the case. And this is a study just also published last year by Dr. Bamad, and looking at the BPD kids with medication use in a large data set in America, and looking at the kids that you can see these kids are exposed to a lot of medications during hospitalization. So the last area I want to mention is the outreach for our program. And it really, we do referral case conferences, annual conferences, and patient reunions. And we do, this is one of our conferences, the brochure for our, actually this March, we did the conference despite the COVID-19 issue. And this is the agenda for the last year's our conference, and they become a really welcomed conference nationally and internationally. And we started patient reunion efforts the last couple of years, and thanks to Kathy's organization, and the parents really, really welcomed this, and our team also felt very much encouraged by seeing these kids coming back. So to put it together, I think to really maintain a good program, you really need to pay attention to all these areas, not just the clinical care. And this is a slide showing our milestones of the program. There are several important milestones from when we first started in 2010 with a small consultation service, to we have the weekly multidisciplinary case conferences, and then become an independent medical team in our unit, and also started the joint pulmonary and neonatology follow-up BPD clinic. These are all very important milestones that we have achieved. So to summarize the key elements, I think, to run a successful BPD program, the first thing is buy-in from all the key players. And then a multidisciplinary team for a multidisciplinary, multi-system disease is very, very important. That you need to have the team to be passionate and enthusiastic, and to have expertise and able to work with an open mind and learn from each other. And then a program platform that encourage open discussions and promote collaboration, and have the leadership to keep consistency and implement changes. Thank you very much. And this is all I want to say. And I'm sorry for the internet connection. I hope we can do some good have some time to do discussions that I don't drop again.
Thank you so much, HUAYAN. I'm so sorry, everyone. I had, this is a disaster of a tech day. I can't put on my video, and I can't access the chat line. So Rahul, our fellow, is now host. And it sounds like Kathy has been answering questions like, little busy bee. So maybe I shall pass over to Rahul to summarize any of the chat questions that he and Kathy have been looking at for you, HUAYAN.
Okay.
Rahul, you're unmuted now. Can't hear you. Hi, Kathy.
Okay.
Hi, how are you?
Good. Thank you for joining. It's so late at night. I can't. We've got almost 100 people online from all around the world. What questions that you should answer?
I do see a question asking about Smoke's Essential program for the families. Yes, we do have a program for that. It's run by our respiratory therapists. They actually went out and got some funding for specifically for that. They have brochures and they have nicotine patches, and they kind of educated our team members, and when we interact with the parents and know they smoke, we will contact that team and they will go for that smoking cessation program. And they actually did pretty well.
Okay, I can see lots of questions popping up, but I can't access the stupid chat page.
Oh, sure.
So
There was a question about if we have a pediatric sleep physician on the list of our attendings.
We do. We've got Vishal Sadi on your attendings, but we've got Vishal
Yes.
Sadi from our hospital online. Is he still there?
Yes, Julie. I was very interested. It's an amazing program and certainly of a lot of interest to us. We've got a very well-developed non-invasive ventilation program looking after about 200 kids in the community. So certainly very interested in the ventilation side of things.
Yeah, there are pulmonologists that specialize in sleep medicine at CHOP. They're not directly kind of part of the team, but the pulmonologists actually formed a BPD consulting service with several key physicians. And they come to us weekly meetings and talk about the patients with us. They see the kids in our unit almost on a daily basis. But if we feel the need for a sleep medicine doctor to be involved, they consult in our NICU all the time.
So a lot more questions on the chat line.
Yeah, I see a question about what is the challenges did you face securing funds for the service? That's a great question. We did have problems with that. When we first started, it's basically on a voluntary basis. Harish and I volunteered our time. And I remember the days I tried to ask my division chief to give me a little bit more time. And she couldn't do that. And then we didn't have funding. And there is a CHEERS initiative at CHOP to support different new initiatives. And we initially applied to that funding and they didn't give it to us. They said, oh, this is a great program. We think the hospital needs to support it. And the hospital said, oh, the department needs to support it. So nobody gave us money. We did that for a while until we actually showed, we did it kind of 3 years later, we did a very good look at our financial status. So we kind of summarized all the admissions and the revenues, and we showed to our division, our department, that this is actually a huge revenue generating service for the hospital and also long-term follow-up for pulmonology and for cardiology for a lot of services. So from that point, all of a sudden people paid attention and start supporting us. It's still mainly supported by our division. Our division chief right now is very, very great with us, and they support our conference and they support our time. And then in 2017, we applied for the Frontiers program at CHOP, and we got the funding for 2 years from that. So it's not easy. It's definitely not easy. I think before you can show you can do something, you ask for funding from the very beginning, people are not gonna give it to you. But once you show that there's some results, you're more likely to get it. Does your unit do cardiac catheterizations for all the BPD babies? No, we don't. We have a very active cardiology, intervention cardiology service, and our PH team is well known, and they are very involved with our patients. But we have a discussion about what kind of patients we need to do CAS. In general, are those patients with severe pulmonary hypertension that when we needed 2 vasodilators and there still may need a 3rd one, we consider for cardiac CAS, but we don't do it for every baby. Or if you think there's some other issues, for example, we find some of our kids actually gradually develop pulmonary vein stenosis. So some of those kids needs to go through CAS evaluation. But we don't believe there's any routine like routine CTs or routine CAS that we need to do for every baby. I think that's the individualized part we talk about. We need to talk about what's the risk and benefit for doing each of these. Next questions, do you give diuretics to these CLD patients? Yes, we do, and we use it quite a bit, and we find there was a creep in our unit to use larger, higher dose and longer duration of diuretics. And that's part of the reason why Nick Bamet did a look at the medication use. And what he found nationally, diuretics is the top medication used for BPD kids. But on the other hand, we don't have a whole lot of data to support the use. So we kind of try to, we would still use diuretics, but we try to find some, we try to monitor the kids carefully to see whether we actually even get any results from it. And if not, we try not to use it for a longer period of time. And this is part of Nick's main research area now, trying to figure out whether diuretics is helpful or not.
I think of oh, there you go. Okay, your internet's back again, HUAYAN. We can't hear you again. Hi, HUAYAN's gone again. While she's trying to get back online, I might, is Dr. Guran still online? Yes, Dr. Guran. Can you unmute yourself?
Do that, thank you.
Oh, Dr. Guran. Can I introduce Dr. Robert Guran? He's our...
Hi.
Hello, everyone. Hi, this is Robert. He's our... what do you call yourself? Executive Neonatal Director, right, of New South Wales.
I've got all various terms. So just a statewide.
Various terms.
I work for New South Wales. I think there's a big argument for getting the consistency of care, and certainly one of our issues is that it's a very big state with a large area, and a lot of families like to be close to home. So there is certainly, it's worth exploring developing a model for the state, particularly getting the respiratory physicians to provide some consistency of advice for getting consistency for how we wean babies off, and basically start to develop statewide guidance based on clinical experience and consistency of care. So of course we can do that, and particularly now we have the Zoom thing going. Caring for these babies is something which really lends itself, I think, to telehealth if there's no if the caring physicians are wanting to be involved. So yes, of course we can do this.
Words of wisdom. Great. So we'll be picking your brains, HUAYAN. Are you back online again? I think we've had a anything from your end, Kathy, that you would like to say?
Sure. Here, I think HUAYAN's trying to get back on now. She just texted me saying she can't see the questions anymore.
Same here. Same here.
Okay.
but don't worry, everything's recorded. So when we send around the link for the recording, the chat page will be on it. Yeah.
No, the consistency and continuity is the biggest piece for our program, and buy-in from our nurses to support what the physicians are trying to do and follow that through to the bedside. So I think that's a really big piece for our program. And also to have conversations with the multidisciplinary team you know, when you're weaning respiratory support, sometimes physicians and frontline clinicians only spend a short period of time, but when you have that conversation with your physical therapist or your occupational therapist or your nurses, you get a better picture of what that whole day looks like versus a snapshot. So those continued conversations are very important.
Okay, so HUAYAN's trying to dial in on her iPhone now. So we've got a few more minutes. So Rahul, you can see the chat page. Is there anything else that we haven't answered?
Oops, sorry.
Ooh. Oh, there you are.
Okay.
This will make for a very interesting recording.
Oh, geez. Let me log out from.
I think it's because you're on your iPhone as well.
Yeah. Okay.
Yeah. Okay. So I was just asking Rahul, HUAYAN, whether there's anything else we haven't answered on the chat page while you were offline.
Okay.
So are we all good now, Rahul?
Can you hear me now? Oh, no, not good.
Yeah, you're echoing a lot. So I think, well, I guess now it's 2 p.m. If there's no more questions on the chat line, please join me in thanking HUAYAN. I think she's gone again.
This is Kathy. I would be glad to send these questions to HUAYAN, and we can answer anything else and send the answers directly to you guys.
Thank you so much. I think HUAYAN and yourself are probably, you guys have a date with the Singaporeans now. You're chatting with them again. So yeah, thank you. Thank you everyone for joining. And please feel free to email me or HUAYAN or Rahul if you have any questions about this chat. And hopefully we'll send round the recording as soon as it uploads onto the cloud. All right,
Yeah,
thanks everyone. I'll
Julian,
sign
back
out from the
here.
meeting now. Sorry, Rahul.
Can you hear me, Julie?
Yes, I can. Oh, you're back again. I was just going to sign out HUAYAN because you've got the date with the Singaporeans now. Yeah. So we'll send round the cloud recording as soon as it uploads, and that will have the chat questions on it as well.
I could always hear you guys the entire time. I never dropped from my end. I don't know why I keep on dropping from your end.
No idea, but I think we got there in the end, and it was excellent. Thank you so much, both of you.
Okay.
Thank you.
Right.
All right. All the best, everyone. Bye.
Right. Thank you.
Bye.
Thank you.